I'm sorry, excuse me, everybody. Good morning, House Healthcare. It is April 15th, tax day. And we are looking at this morning H237, which passed the Senate. This was a bill we did last year before crossover. If you remember, the bill reporter on this was former Representative McFawn. And we have the bill reporter from the Senate in to walk us through and hopefully refresh our memory about what the bill is, because a year is a long time.
Yes, indeed. Thank you for inviting me up, Chair Black and Vice Chair Rebecca. I'm happy to be here with everyone. I normally don't read my floor reports when I do this kind of intro, but because this was kind of late notice and this is a lot happening as I'm feeling like we're heading toward the end of the session. Everything's starting to get pretty tense and exciting. But yeah, so I will probably just read through this and maybe skip some parts, but just to give you an overview, this is H237. This is an act relating to prescribing by doctoral level psychologists. In times of crisis, we require innovative thinking and changes to existing structures. Since COVID, we've talked a lot about a mental health crisis, and across the country, practitioners are examining new ways to treat patients. Here in Vermont, as in many parts of the country, the mental health crisis is coupled with a provider shortage, making treatment and care even harder and more elusive for those struggling with illness. H237, an act relating to prescribing by doctoral level psychologists, is one step toward alleviating some of the stress on Vermonters and health practitioners. To be clear, this bill is not going to solve the problem. It's just one tool in the toolbox to ease the potential harms of provider shortage. As you know, H237 came to us from Representative McFawn, who found that in his region, some folks were really suffering from mental illness, and they were facing barriers to accessing critical medications in a timely fashion. That's the problem we're trying to solve. This bill will allow certain doctoral level psychologists to prescribe medications. The bill contemplates a scope expansion, and because psychologists are regulated by OPR wrote a Sunrise assessment in January of 2025. I always like to say, if you haven't read their reports, this one is really helpful. I highly recommend it. A little history of this practice: psychologists prescribing began in the military, actually, in 1991, with a scope of practice expansion that was tested and was deemed successful. Since that time, 7 states have implemented legislation authorizing psychologists prescribing: Louisiana, Illinois, Iowa, Idaho, Colorado, and Utah. And this practice has been successfully in place in New Mexico for 20 years. Mr. President, Madam Chair, I'd like to read from an article we were presented with in Health and Welfare. It was published in the Pennsylvania Psychologist, Why Psychologists Are Uniquely Positioned to Prescribe Psychotropic Medications. As the field of mental health continues to evolve, a more integrated and nuanced approach to care is emerging, one that values not just symptom reduction, but deep understanding of human behavior, cognition, and emotional functioning. Psychologists are well poised to have this scope expansion because they have a broad therapeutic toolkit. Psychologists are extensively trained in the full spectrum of non-pharmacological interventions, including psychotherapeutic approaches and behavioral interventions. Prescribing psychologists can situate medication with a broader, holistic treatment framework. Combining talk therapy with pharmacotherapy tends to deliver better outcomes than pharmacotherapy alone. Psychologists note that they are uniquely situated to offer bimodal care, for example, talk therapy and medication, which is rarely possible in a primary care setting. Some within the medical community are concerned about the overuse of psychopharmaceuticals. However, psychologists argue that their training will tend to generate more conservative prescribing, better ability to titrate medication, and the ability to follow patients across time and assist with de-prescribing. My last statement was, in our quest to increase access to care, improve quality, and lower cost, we voted the bill out of committee 4-1-0.
To her thing.
Well, just send me what she said. It's funny when you're talking, it's like some of the points it's all coming back to me and I'm like,
Yeah.
oh yeah, that was that point. Go ahead, Beth.
Thank you. What was the Senate vote?
4-1-0.
That was committee.
And that was the Senate vote. I'm sorry. We didn't do a roll call, but it was, it was not unanimous, but close. Actually, my seatmate, voted no. She is a, social worker and she is worried about overprescribing. So that is something that she couldn't get over to vote yes for the bill, on the bill. Yeah. Thank you.
Thank you.
You're welcome.
Senator for coming in.
For the hard copy, Madam Chair, or?
If you would you like it back so you can?
No, I'll make my own copy. Thank you so much.
You framed all of them.
No, they end up in the recycling bin, I'm afraid. Any other questions?
Thank you.
I guess I got a question. I don't know if it's, like I said, this one's kind of new to me. I'm with her refreshing it. But the psychologist means a person who's licensed to practice psychology under this chapter. Psychologist, doctor, same definition.
Doctoral level, yeah.
The master's same. So if they're all the same, what's the difference?
So this bill contemplates a psychologist who has a doctorate, so
Yeah.
a doctoral level psychologist who then, and you'll get into this, but goes through a whole process of training and coursework to get that
So
ability to.
Some of the education is a
prescribe.
little different for those.
Yeah,
Okay.
yeah.
We have OPR coming in and they can help refresh us
Okay.
on.
Yeah.
I know, again, it's been a year and
Yeah.
Thank
you
you.
remember who we're talking about here.
Thanks. Thanks, everybody. Yeah.
Thank you.
Thank you.
And I know I'm putting you on the spot here. I was wondering, do you have sort of like a side or I have it sort of highlighted where it changed? 'Cause I know it's a strike call.
It is a strike call. I have a document. It's not a side by side, but I think it might be helpful. So let's take a look at it. And if it's not helpful, we'll come up with a new plan. Guess I should start by saying good morning, Katie McMahon, Office of Legislative Counsel. Nice to see everybody. You know, it's been a long time since this committee saw this bill. So what I have is a section by section summary of the bill and the changes made. This says by Senate Health and Welfare, but it's Senate are in red. So that kind of brings us directly to the places where there are differences in the draft.
Is that in our thing? This?
No, but it can be if
That'll
you
be-
would like it. I could send it to
Yeah.
Tasha.
Yeah.
Okay,
Yeah.
I will definitely do that. So the first change is in section 2 of the bill, which is the powers and duties of the board. So it directs the Board of Psychological Examiners to adopt rules on various topics. What you passed, some of those topics included settings of clinical rotations and prescriptive authority, including the designation of conditions and drugs excluded from that authority, as well as requirements for prescribing of particular drugs. And subdivision B was added. So if you're looking at your draft, that is page 3, lines 15 and 16, the minimum requirements for the curriculum of a postdoctoral psychopharmacology program. So that is an addition from the Senate, that subdivision B.
What does that mean?
I know.
Maybe that's.
Pretty much the minimum.
Oh, the minimum
requirement.
requirements for the
Right.
curriculum
Mhm.
that will be submitted to the Board of Psychological, like each curriculum will be submitted, is that?
No, but what the curriculum would have to involve in order for somebody to receive the specialty designation that's contemplated in the bill. So somebody would have
that.
the doctoral levels. Oh, who reviews it?
Yeah, yeah.
The board.
Okay, so that's what I meant. So it is done by the Board of Psychological Examiners. Yeah.
Okay. Next change is in section 3 of the bill. So if you go to section 3, subsection B, that's page 4. And we're looking at lines 18 through 20. So in both bills, you have language that the individual has to have completed clinical rotations over not less than 14 months. The Senate version has a not less than 5 practice areas, and your version had a not less than 9 practice areas. And your version lists including psychiatry, pediatrics, geriatrics, family medicine, internal medicine, emergency medicine, obstetrics and gynecology, surgery, and 1 elective. The Senate version is psychiatry, geriatrics, family or internal medicine, emergency medicine, and neurology.
Who did, who?
Yeah.
What did you get rid of?
Reduced from 5
So
from 9.
surgery, 1 elective.
Surgery?
Yep, obstetrics and gynecology. What else? Let's see, we have psychiatry, pediatrics. We have family medicine. It combines family or internal medicine, the Senate version, and you had them listed out separately.
Okay.
And it adds neurology in the Senate version.
You know, if there's some rationale behind.
I think this was advice that they were receiving in testimony. So you have the Vermont Medical Society here and you have OPR, so
Okay.
I think it was-
I actually remember vigorous discussions about all of these specialties last year. Can't believe the things I can remember.
I know.
So does that mean that they're being excluded from treating children?
this does say that they don't treat under 18.
Okay.
Okay. Next change is a new section that's being added. So that's section 4 of your bill. There is a new reporting section that the Senate added. This requires OPR to submit a report to the policy committees by November 15th of 2032 regarding the number of psychologists with a prescribing authority or specialty, the status of available collaborative practitioners, and whether any updates to the qualifications of prescribed psychologists are necessary to expand access to care while ensuring public protection. And then, of course, the dates had to be changed because this wasn't acted on last year after you sent it over. So we have an update of the effective date number because a new section was added. And then you have sections 2 and 5. So the effective date section and setting up the powers of the board. That takes effect July 1 of this year. And then the remaining sections, the reporting, the definitions, and the actual specialty take effect July 1, 29.
So was it 25 and 28?
Let me double check, but I think we just moved it back here. But let me. No, so this would have taken, the specialty would have taken effect July 1, 26. So this puts it out by a couple years. If I had just bumped it out 1 year, it would have been 27. So they bumped it out 2 additional years to 29. Do you want me to say that again?
No, I heard you. I'm just wondering, do you know any rationale for why? Bumped it out? Or is that something we should ask OPR, or is that something maybe we could ask the Vermont Medical Society? Oh.
We went through Vermont Medical Society. This was an ask from the Office of Professional.
Okay, we'll ask OPR.
Okay, and that's it for the changes.
Okay, I know, could you walk us through the whole bill?
Yeah, I would be happy to.
Yeah. Just- I'm sorry, I wouldn't normally do this, but.
No, it's been a long
it feels
time.
Like it was eons ago.
That makes sense.
Did it happen at all?
That's what we're.
Yeah. A little bit.
Yeah, there's also 3 new people.
Yeah.
Okay, so here is the Senate proposal of amendment. What is happening just structurally, mechanically, is that there is a chapter pertaining to psychologists. So we're amending the definitions of psych in that chapter on psychology. And then there's a new section itself being created specific to the specialty for doctoral level prescribing psychologists. So in terms of definitions, we're adding a definition for collaborating practitioner. This means a physician licensed to practice medicine with a specialty in psychiatry. So in this bill, you'll see that a prescribing doctoral level psychologist has to work with a collaborating practitioner. So meaning that each psychologist is working with a psychiatrist, and they're only prescribing drugs that would be in the psychiatrist's traditional practice. So we have some definitions of drug and DSM. The prescribing psychologist means a licensed doctoral level psychologist who has undergone specialized training, has passed an examination as determined by rule, and has received current prescribing specialty pursuant to a section that we'll look at, that has not been revoked or suspended by the board. Definitions of prescription drug, prescriptive authority. This means the
I'm sorry, man. I think it's interesting that this last line, that has not been revoked or suspended. I mean, is that implying it might be or has been? Or are you saying it hasn't been prior to this? How does that work?
So this is saying that the person has a specialty or a license that is in good standing.
I've never seen language like that regarding a license before. And, you know, we look at all these different licenses. So, okay, it's just saying it's got a license in good standing.
Mhm.
That's the point.
Mm-hmm.
Okay.
I have another question.
Sure, go ahead.
So I think the removal of the pediatrics section is gonna come up as a question perhaps because that was something that went over with it in and then they removed it.
Mhm.
So under, if you can go up and so I can remember how to phrase this, is there a difference between prescribing psychiatrists or is there a difference in title? Like psychologists or pediatric psychologists, would those be two different certifications or licenses?
That would be a better question for OPR if there's a specialty for pediatrics
Okay.
and psychology.
Okay.
Yeah, I'm not sure, but I bet they are certain and they could give you an answer. Okay, 17, prescriptive authority. Means the authority to prescribe or discontinue prescription drugs solely for the purpose of diagnosing, treating, or managing a condition recognized in the DSM, Diagnostic Statistical Manual. Prescriptive authority excludes the authority to, so meaning doctoral level psychologist is not authorized to dispense, administer, or distribute prescription drugs, and not allowed to prescribe or discontinue prescription drugs for patients who are less than 18 years of age, over 80 years of age, or pregnant. Okay. Section 2, this is the powers and duties of the board. We just went through this, but one of the powers is to adopt rules, and then we have a list of what the rules would contain. So new language is regulating a prescribing psychologist, including settings of clinical rotations, minimum requirements for the curriculum, prescriptive authority, including the designation of conditions and drugs excluded from that authority, as well as requirements for the prescribing of particular drugs.
Can you refresh my memory why we struck out the explain, complaint, and appeal procedures?
Above,
Yeah, why did we strike that?
I couldn't tell you at this point why you struck it. It's been too long. I don't.
I'm just wondering, is it like it's somewhere else, so you got moved somewhere else, or?
It's not specifically mentioned anywhere else in this bill. I don't know if it lives somewhere else. I don't
Okay,
have a recollection of that.
all right.
Okay, and 4, regulating collaborative practice agreements. Those are the agreements between the psychiatrist, the collaborating practitioner, and the doctoral level psychologist.
I have a question.
Go ahead.
Did we, this is more of you, did we get testimony from a psychiatrist? About,
Yes.
I think we did, right?
Yes,
That-
we did.
And that, thinking that this was a good thing, that they were willing and well, that one person.
Except for one.
Oh, yeah, of course. Okay, thank
Oh,
you.
yeah.
Trying to
And
remember.
that's all coming back to
Yeah,
me.
I need a little sugar here.
Yeah.
Yes, there was. I think that, I'm sorry, Stephanie, would you mind? I think in general, psychiatrists were in favor of this. That was the position of the Vermont Medical Society.
Yes, Stephanie Winters, Deputy Director of the Vermont Medical Society, I also serve as the Executive Director of the Vermont Psychiatric Association. We don't generally support the bill, but do support safeguards added to the bill that included having a psychiatrist as the collaborating practitioner.
It's all coming back.
Everybody.
Sound familiar? Yeah.
Yeah, can I ask, or maybe you'll test why you generally don't support the bill?
I think, sure. We don't generally support the bill because we don't believe that it will have impact on access. We don't believe the need is for medication. We actually think there's more need for psychotherapy, talk therapy, cognitive behavioral therapy, and so more medications is in the system is not what we find that we need, since primary care can already prescribe psychiatrists. So that was our position, but we do support a number of the safeguards that have been added to the bill.
Thank you. Thank you. I looked it up I just want to remind everybody that the committee vote on this bill, when we voted it out of this committee, was 10-0-1. So and we spent a lot of time, I remember, on testimony on this bill. Okay, thanks, Katie. Wanna keep going?
Section 3, so this is the section I alluded to earlier. This is the new section specific to the prescribing specialty by doctoral level psychologists. The subsection A allows a psychologist doctorate to apply to the board for this specialty. The application is made in a manner approved by the board and includes payment of any required fees. In subsection B, it says that the individual is eligible for this prescribing specialty if they hold a current license to practice psychology at the doctoral level in Vermont. They've successfully completed a postdoctoral training program in psychopharmacology designated by the American Psychological Association or its successor. The person has completed clinical rotations in 5 practice settings. We went through that. Top of page 5, they've completed a national certifying exam as determined by rule, and they meet other requirements for obtaining a prescribing psychologist specialty as determined by rule. And then we have the criteria for prescribing. There's a requirement that there's a written collaborative agreement for all prescribing psychologists practicing under a prescribing psychologist specialty issued pursuant to this section. In subdivision 2.
Can I ask a question about that?
Yes.
Is there, maybe it's for OPR, but is there just a standard collaborative agreement that one can use, or is it, they have to create a whole new one?
Every time, that's a better question for the field, I think. Subdivision 2, the issuance of prescriptive authority by a collaborating practitioner to a prescribing psychologist shall only include prescription drugs for the treatment of mental health conditions that the collaborating practitioner generally provides to patients in the normal course of their practice. The collaborating practitioner is to file the collaborative agreement with the board and any notice of termination of the agreement. Issuance of prescribing authority for Schedule 2 through 5 controlled substances shall identify the specific controlled substance by brand name or generic name, and prescription or administration of a controlled substance by injection is not allowed. And we have specialty by endorsement, that the director of the board of psychological examiners may, upon payment of the required fee, grant a prescribing specialty without an examination, if the person holds an active psychologist prescribing authority in another US or Canadian jurisdiction, and requirements for psychologist prescribing authority in that jurisdiction are substantially equivalent to the requirements in this section. We have the new report that we just looked at, so I won't walk you through that. And then our effective dates.
Thank you.
Thank you.
You're welcome.
Great. Any questions for Katie on like the language or understanding any piece of it? All right. Thank you, Katie.
Yeah, you're welcome.
Thank you, thank you.
I know we have, Jennifer, I was gonna say, I know we have someone from OPR. I'm just not sure who it is because I don't have my agenda. Hi, Jennifer, how are you?
Great, thanks. How are y'all?
Thank you for coming in on short notice.
Happy to do that.
So I was hoping you could sort of tell us about the changes that the Senate had made and sort of the rationale for them.
Happy to do that. For the record, Jennifer Colin, I'm the director of the Office of Professional Regulation. And just so you're aware, I'm supposed to be with y'all at 10 o'clock also, or
Yes.
10:15. So I'm going to run from my office once I'm done and head over to join you in person. But thanks for having me today on H237. This is a bill that would allow a scope expansion for psychologists to prescribe with additional training, education, and we would do that through a specialty specialty that we offer. That specialty costs $100, and you did see this bill, but there have been a few changes that you've heard about today, and happy to review those with you. I think the primary changes in H237 relate to the number of clinical rotations that's required and what those areas of clinical rotations, what areas of study those clinical rotations are in. So originally we had 18 months of rotations, and the bill now has 14 months, and it removed the requirements for rotations in pediatrics and obstetrics and added a neurology rotation. And my understanding of why that change was made is because with the limitations on the scope of practice, where prescribing psychologists aren't prescribing to pediatric patients, nor are they prescribing to pregnant patients, those rotations were removed, and psychologists would be allowed to focus more on relevant training, I think was the reason for that change. And then other changes, there's a report back. So whether the Senate was concerned about whether the limitation of the collaborating practitioner being a physician licensed to practice medicine, there was some discussion about changing that requirement to potentially include other types of practitioners, particularly APRNs, and potentially other practitioners. But it was left with a collaborating practitioner being required to be a physician. And I think the report back was to kind of assess whether that's adequate, whether there are enough collaborating psychiatrists in the state who are willing to work with psychologists who are getting this specialty. So just trying to determine whether there would be some sort of barrier or access problem if that requirement was left the same. So we're going to report back in 2032, I believe. And then the last change is the effective date. It was July 1st, 2026. we asked for that to be changed to 2029, simply because we're going to have to go through rulemaking. And we, given our list of priorities right now, and the fact that we are currently undergoing kind of some mental health licensure reform. You're going to be hearing about that a lot next session. We're in the process of kind of bringing all of the mental health professions under one board, with the exception of psychology, but we're going to be doing work in all of our mental health profession statutes to streamline requirements and remove unnecessary barriers to access to licensure, because we do have a mental health crisis and we need more practitioners. So OPR engaged in a 2-year study at the request of the legislature to figure out where can we streamline and what can we do to create more access. So we did that 2-year study. Now we'll be coming to the legislature next year with some statutory changes, and then after that we'll be doing rulemaking in our mental health profession. So being able to just do this rulemaking for psychologist prescribing, kind of in conjunction with that other work, would be the most efficient way for us to go about it. So that's why we asked for that date to be changed.
Great. When do you anticipate that you'll be done with, I know you've been working on this project for a couple of years of sort of aligning the mental health professions. When do you anticipate that's going to be done?
Great question. So depends on how long the legislation takes to get through the legislature. So we plan to come into the legislature next year with proposed statutory changes in all of our mental health professions. It's going to be a substantial reform. And then once those statutes pass the legislature, then we'll have rulemaking. And again, with that impacting all of our mental health professions, we expect that that's going to have extensive stakeholder outreach. And so we're hoping within a year and a half after the statutory changes are made to be able to have our rulemaking complete.
Great. Thank you. You have that to look forward to for any of us that may be here next
It's
year.
very exciting.
Yeah, I know it's been on their plate.
Did anyone have any questions for Jennifer?
I just had my very
Yes.
simple question. The bill asks for a written collaborative agreement. That's on page 5, line 5.
Yeah.
I was just wondering if there's a standard form. Does it have to be created each time? What's the support for those kind of collaborative agreements?
The collaborating psychiatrist and psychologist will come up with their own collaborative practice agreement that meets the requirements of the statute. And there may be additional details around that in administrative rules as well. So they'll come up with that together.
Great.
And then there was another question I think that someone had: why did we strike explaining complaint and appeal procedures?
Yes, thank you.
Yeah, no problem. In 3 VSA Title 3, we have all of our statutes that apply to all OPR professions. And so board procedures and appeal procedures and whatnot, they're all in Title 3, primarily in 3 VSA 129. So
this was redundant and we were just cleaning it up.
And as we're going through and having changes in the different Title 26 chapters, we're taking that out whenever we're doing revisions.
All right. I knew it had to be something like that, but. All right. And I guess since I have you here and just, you support the as passed, OPR supports the as passed by the Senate.
I'm sorry, that should have been the first thing I said. Yes.
Yeah.
OPR
Okay. All right. Thank you. Thanks for joining us short notice, and we'll see you in a few probably.
Shortly. Thanks so much.
Um, All right, any questions about this? We do need to straw poll on whether or not we can, yeah, go ahead.
I think I just need a little bit of conversation.
Oh, sure.
Let's. So I'm obviously not a doctor. And so it's just a little personal. I'm not a huge medicine person. I just like to solve issues naturally with your body, you know, whether it's adjusting food or whatever. I just like the more natural approach. So I obviously don't know the medicines that will be prescribed in this situation. I'd kind of like to. That it's hard for me to just say, yes, this all sounds good, but I feel like you go to the doctor. Because your head hurts, or I don't know, like when I think it's hard not knowing what mental issues are, a list of them, what medicines would be prescribed. Do you need the medicine? Can you, so I mean, this morning I was just going through it and that's what I'm struggling with. I'm struggling with the information in front of me saying this medicine should do this because the doctor can't do this without that. Does that make any sense?
It makes total sense. I'm sitting here and I'm like going through all the documents that we had on the testimony that we took on it last year. Because I know that those were all questions that we sort of had last year. Let me,
And maybe we'll hear comments.
yeah,
Is this conversation time or not necessarily?
let me go to Leslie's question and let me
Question, I'd like to respond as a
something.
clinician.
Would you like Lori to respond? Leslie to
I mean,
respond?
I'd love to do Lori, but anytime we could have a dialogue offline, but as a clinician, when I look at this bill, I'm seeing it as a tool, one more tool, not the only tool. So if you're seeing a psychologist because of anxiety and depression, which is the most common, I think, things that people see, it may be that cognitive behavioral therapy and all the tools are not really helping the person get beyond where they're at so that they can move on. And that being able to prescribe a medicine might help with that leap to the next level of healing. And if a psychologist who's trained in this sees this as a good tool, then they're going to have to refer to someone who can prescribe, which might be an APRN because there are psychiatric nurse practitioners or psychiatrists or whatever, but that's going to delay care for that particular person. Whereas if they're able to prescribe and add it to the work that they're already doing, that can help the patient move through quicker. And that's how I'm seeing it.
And yeah, hold on one second.
Does that make sense? Yeah.
And I recall, I mean, because we had, long discussions about this and we had a lot of witnesses in on this, that one of the reasons that we were doing this is that current practice is that the medication is actually being prescribed by a psychiatrist or an APR, a psychiatric nurse practitioner, but they're not the ones who are having that longitudinal frequency relationship.
Once a week, maybe?
With this, once a week or even multiple times a week, with that psychologist who is providing, like the cognitive behavioral therapy or, the therapy. And that person is the one who is seeing, they're the ones that are actually gauging how the pharmaceutical management is helping, hurting, all of that. And it was a barrier to care to even make changes with someone's medication because the person who's actually seeing them on an ongoing basis wasn't able to do that, which is why there's that whole collaborating agreement piece of it. Because you'd be working in collaboration with a prescriber, but you'd be able to make those real on time, real time decisions to change or remove or tweak medications. I guess, Daisy, I'm sorry. Just wanted to hand on.
Can I
Close
speak
this.
as someone that has multiple specialists? So like I have a psychologist who this would benefit because I see them more regularly. I'm on tons of medications for chronic conditions, including seizures. So I can only get into my neurologist once every about 6 months now. Used to be once a year. Once every 6 months. So if I want to reduce a medication, this would allow my psychologist to communicate with the neurologist through like the EHR or whatever and say, hey, I'm starting Daisy on this other thing that's co-indicated with Topamax or whatever. And they could step me down from that medication and they would communicate with each other to say like, okay, she's having side effects or whatever. But it helps me from having to wait 6 months of dealing with side effects of a medication that my neurologist put me on that does not work. So for me as a patient, that's why this bill, I was like, yes, I need this because I don't want to be on all these medications, but I need to be on them neurologically. So for people that have to, it's really, really helpful.
And I think kind of to Leslie's point that in the testimony that we heard was that it actually would lead to less prescribing of medications because the person has an ongoing relationship with you, a therapeutic relationship with you, would be less apt to prescribe because you're doing other things. Whereas if it's just somebody that you're seeing, once a year, once every 6 months for pharmaceutical maintenance, they're just prescribing to you because that's the only tool that they have.
Right. And drugs get prescribed that way too.
Yeah. And that was actually one of the things where, we heard testimony that it actually would decrease the prescribing of medications because it would be
It's very well taken.
Yeah,
Absolutely. It's got to be part of an entire therapeutic plan and not just an automatic and looking at the entire person, exercise and diet, everything that we know that helps mood. But this is just an additional tool.
And I appreciate the age.
Yeah.
Did we take testimony on the percentage of doctorate level psychologists?
we did take testimony on the number that we have. We also took testimony on the number that we thought this would affect. And I do remember that it was a very small number.
Yeah.
And I'm sitting here looking because I remember this vividly, the chart that gave the timelines for training, and it compared psychiatric nurse practitioners, physician assistants, prescribing psychologists, psychiatrists, and primary care physicians. The point being that all of those can prescribe except for the doctoral level psychologists, and the training and the education and the clinical experience that's needed for, by the time this bill, like all the requirements, that their timeline for training and experience is actually equal to a psychiatrist.
So that was my question, because by far the more, most of the psychologists, right, are not going to be able to prescribe medication. And their method of therapy is not just to prescribe drugs. For the most part, they do other things. So by far the percentage of psychologists are not going to be prescribing drugs. They're going to be relying on their therapy techniques that they've relied on all the time. So
They also would have to go through that entire
Yeah.
training thing.
To go through it.
Enormous.
I think it's
14
2 years.
months.
Yeah.
14 months.
Well, no. 14 months is just the clinical rotations. There's a 2-year training
Then there's the
in psychotherapy.
psychopharmacology. I think it could be something that
Yeah.
attracts clinical psychologists to Vermont, knowing that they might have access to this benefit. So it's also a little bit of a workforce, hopefully, benefit. Yeah. Enticement, whatever, that we get more people here.
And, sort of our constant refrain in this committee is practice to the top of your license. Go ahead,
And
Daisy.
coordinated care, right? Like we want a coordinated system of care. And I think this, like the agreements allowing providers coordinate and to talk to each other. That's what we want. What I want my providers to do anyway. It's more efficient and they can learn from each other's expertise.
I think sometimes in mental health, people worry that we just keep adding medicines and don't remove them. And I think having this kind of education and knowledge of the person will allow reduction of medication use as well. And I think that's.
I am more than happy, considering I'm the one that has to report this on the floor this afternoon. I'm more than happy to delay a straw poll on this until tomorrow. If you want to maybe spend the rest of the day or this evening kind of going through the testimony that we had on it previously. I mean, I know it's a lot to put on a new person who wasn't here last year to make a decision about it. And I'm more than happy to give you time. I can also help you and anybody else here to line up maybe someone talking to you through some of your questions.
Well, I just want to
Because
make
you
sure
didn't
that
have the benefit
training,
of being here.
I mean, when I Google the psycho, I just, psycho. Okay, doctoral level psychologist.
Mhm.
When I Googled what they had to go through, it was very extensive, their training.
And that's just, you have to actually be that doctoral level to even then do the additional training to be able to prescribe. Yeah,
That's.
yeah. Yeah, and I, just for the record, I have pulled up on my laptop the chart we got in our written testimony. That's
Time.
all the people that can prescribe. And what this bill would do is this pink line here, that would be the education experience that all that they would need, which is exactly equivalent to a psychiatrist who is an MD or a TO or a primary care physician even.
Okay.
All right, would you, do you want more time? Does anybody
No,
feel like they
I-
need more time?
I just,
I'd like to do it tomorrow. I'd like to see the senator's report that she put in, just to review that one. Her testimony today.
Oh, okay.
I'd like to see that.
Right, Tasha, do you want me to, can you? I asked her for a hard copy of it, so could you scan that in and post that on our committee page? Sure.
If it's not gonna be a big deal, I'd like to understand it a little more here.
Okay, all
We
right.
should delay it 2 days, maybe.
No, I'm gonna vote on it tomorrow.
No, I mean your report.
No, I'm not gonna delay for 2 days.
Yeah.
I'm gonna vote on it tomorrow before floor, and I'll report it out on the floor tomorrow. It's up for action. It's up for action today.
I think the Senate total was a closer vote than she thought. I think the committee was fine, but I think the total, I think it was 11.
That was on an amendment.
Oh, that was just on.
There was an amendment that, various committee members in Senate Finance
Okay,
had put, and I believe the amendment was to strike am I correct, strike over age 80?
Yeah, I would strike
Okay,
over AG and have more specifics about the collaborative agreement and assessing a person's overall well-being before having a prescribing psychologist.
Yes,
Yeah, that was 11:15.
that was 15, so that was, and
okay, yeah.
that was actually, do we use the word defeated? Oh.
Unfavorable.
Unfavorable, there we go,
That
thank you.
that
Leslie.
amendment was unfavorable on a vote of 11-15. And so that stuff is not in this bill because it didn't pass. And then I think it just passed on a voice vote. But do you?
I think overall, I'm supportive of it, okay, I'm just still a little confused about something.
You know what? I think that we should wait. Let's wait for tomorrow. I'm going to take a straw poll on it tomorrow. Let everybody think about it overnight. Maybe review the witness testimony that was received in both this committee last year as well as health and welfare this year. As well as I'm sure there's some documents in Senate Finance.
I'm also happy to talk to anybody. I'm a patient that would be impacted by this drug, so I'm happy to talk to anybody that's.
Why does it go to Finance in the Senate? Is it because it's sort of OPR?
I think it's because it says something that there could possibly be a fee.
Oh,
Actually, what? A fee
There
for
could
the
possibly
special.
be a licensure fee.
fee.
Yeah.
Oh, yes.
Can you just?
So that's why it went to Finance.
That's something on process. So we're voting tomorrow. The straw poll is on the amendment.
It's on
Bill.
the Senate did a strike all, which they basically took our bill 237, they struck it out and they replaced it with this. But Katie walked us through what the actual real changes are. So it remains unchanged except for those 3 areas four areas that she highlighted for us.
Okay,
So those are really the only changes.
okay.
So, yeah, it is a strike all. And so that's what we have before us.
Okay.
So what we would be straw polling is, do we concur with the Senate proposal of amendment? Okay, all right, we'll do it tomorrow. Put that on the schedule for tomorrow. Great. Thank you, everybody. All right. Let's move on. I have a copy of, thank you. Oh, we have to wait for Jen. Let's take a break. We'll wait for Jen to get here.